without further ado, I'd like to introduce Professor Judith Chopin to be able to introduce Matthias. Judith is the Director of the Haematology Clinical Research Unit and Senior Haematologist at Concord Hospital here in Sydney. She's particularly expertise in management of lymphoid malignancies, and she's a member of the ALLG and a chair of the low-grade lymphoma group as well through that institute. She's a chief investigator of a number of trials that are in Australia, and she'll be great to be able to talk to us later on about some of the trials that are coming through Australia and through the ALG group. So please like to welcome Judith.
Thanks, Donna. And I'll
No
take
worries.
that off you because
Thank
we
you.
need it for the webinar. Gosh, it's great to see you all and all looking so well, all right? Okay, I don't see a single sick person amongst you. Would you not agree, Matthias? And you and I are very good at sorting out, assessing people. You all look fabulous. You all look healthy and strong. And I think that's one of the key messages I want you to be getting from your Lymphoma Australia communications and from your haematologist, all right? Follicular lymphoma is a long journey, all right? And it's about us helping you on that journey to make the right decisions for your own health care. I'm very privileged to have Professor Rummel here tonight, or today. It's interesting, when Professor Rummel comes down under, he becomes Matthias rather than Professor Rummel. And we're very grateful of how Australian he is and how informal he is here in Australia. He's given some amazing talks in the past for Lymphoma Australia. Are you going to tell us the sliced bread story, or do I get to say that?
You can say.
It's in your slides?
No.
No, okay. Well, a couple of years ago, I invited Matthias to come and talk at a forum that we had at Concord Hospital. And I had to get a sexy title to get you all to come. So I had bendamustine, the best thing since sliced bread, ? Now, of course, that's a very sort of Kiwi, very Australian sort of saying, and someone from Germany has no idea what that means. So Matthias actually did a Google search, and he then also gave us a 2-minute expose about how sliced bread was developed in, 1904, and it was this amazing invention. So I'm sure a lot of the focus on his presentation today is going to be about bendamustine, which has been a huge welcome to the armamentarium of our management of follicular lymphoma here in Australia. But let me tell you a little bit more about Professor Rummel. He is the professor at the university and the hospital in Gießen, Germany, and the head of haematology there, has had a long-standing and consistent leadership with the German lymphoma group still in low-grade lymphomas, and has, they have churned out so many really important, relevant clinical trials that have been, world practice changing, and we're really looking forward to hearing from you. Come on up, Matthias. Welcome to Australia. Thank you.
Yes, will do. So thank you very much again for having here the chance and the opportunity to be in Australia and to discuss. I do it most often with colleagues, with doctors from different cities, and also I have had the chance here the second time during my trip here to discuss with patients. Also, I was invited to discuss with nurses already 2 times, and so the same happens in Germany also. Patients are organized and invite doctors sometimes to hear from the doctor what is the news, and more important, to ask some questions. And interesting when somebody asks a question, that's also interesting for the other person next to him, because it's interesting who has questions and what kind of questions and what is the type of answer for that. Sometimes, as in political debates, there is no perfect answer. Yes, so you probably vote for the one party, the other one for the other, and both thinks they are absolutely right. And probably there are good reasons to believe that everybody has a good opinion on that, but it may differ. And so I'm coming from Germany. This is the background slide. I just saw it, that it was popped up, a typical area in Switzerland and in North Italy. I'm living in Germany, but I go there very often. And I was once hiking here this way, all the way through the cliffs until the summit. And I just did it here because this is an interesting atmosphere when you walk there alone in the early morning, because I didn't know if I ever will make it to the summit. Therefore, I started at 8. I'm not experienced. I live in a big city, so I didn't know if I can make it. But when I was hiking, really, that is the reason why I'm telling you, I was thinking about what could be another interesting clinical trial, because this was my whole professional life, to create and develop a new clinical trial and to ask a relevant question. That is my main objective and my main motivation, to do a clinical trial on a very relevant question. And this is not necessarily what is usually being done, because usually a pharmaceutical company who wants to develop a new medication, which is absolutely critical and necessary, they ask the question, is this new medication good enough to become registered by the TGA, by the FDA, and by the authorities worldwide, and then later it will be available as a prescription in the medicine for the patients. This is the big need to have some new treatments. But once the treatment is out, you may ask, should I repeat the treatment 4 times, 6 times, 8 times? What is the best dose? Can we combine it with another treatment? And these questions, maybe they come from doctors who are interested, and we call this treatment optimization or investigator-initiated trial, which is different from a pharmaceutical industry-initiated trial. So this is my main motivation, and of course I was not born with this motivation. When I was selected by a professor of medicine as a young doctor, he invited me to become hematologist, and my very first day he told me, you are responsible for a clinical study. And when that is the first thing what came to your mind when you are a young doctor, then probably you continue this kind of things what you are having been introduced to you. So this is my story and my background. I work in Gießen, and Gießen is a city 50 kilometers north from Frankfurt. I live in Frankfurt, but I every day go by car to Gießen back and forth. It takes me about 30 minutes, and so it's not a big problem. Gießen is a more academic city. Only 100,000 people live there, but I have many, many patients, because all cities around Gießen and in the federal state Hessen travel to Gießen, because we are a center of expertise. We have a teaching hospital. We call it Hospital of the University of Gießen. So today I'm going to talk about the disease called follicular lymphoma, and I would try to make an update, or I give you the information of the most relevant clinical results. And so I hope that you can understand a little bit the detailed and the background of the treatment decisions the doctor may discuss with you. Also, I realize, as in every country, when you go to one doctor in Australia, he will recommend you treatment number 1. When you go to the second doctor, he will maybe recommend a different treatment. Maybe it's a small difference, but it looks for you a big difference. Maybe indeed it's a totally different treatment approach. And we will discuss these very important questions during my talk. So follicular lymphoma is one of the diseases which is called non-Hodgkin lymphoma, and here it stands 22% around. Statistics is follicular lymphoma, a subtype of the non-Hodgkin lymphoma. The other disease which is different is the most often disease diffuse large B-cell lymphoma, that is 31%, but these just belong to the same family of diseases but are different biological diseases. Follicular lymphoma, and in follicular lymphoma, it's a disease, as Judith just mentioned. Many of you look quite normal and healthy and fit. Of course, sometimes when you have the disease with symptoms, you do not look in such a good shape, but this is different from the other disease, because in a low-grade lymphoma, in a follicular lymphoma, sometimes the disease is only growing slowly, and the symptoms of the patients are rather low sometimes. I would say most frequently. But some patients, of course, have a lot of symptoms and a lot of disease burden. So sometimes it happens that you get it diagnosis by chance because you realize a lymph node growing here and this irritates you, but you feel healthy. After a few weeks or months, you go finally to your doctor and he says, okay, you have nothing more serious. We just look what happens. After 6 months, suddenly somebody makes a biopsy of this lymph node, and then you have the diagnosis. It's a follicular lymphoma. And in that moment, when you then go to the specialist, he may recommend to you, yes, it's a malignant disease. He is explaining to you the type, and finally he says, but we will not treat it at the moment. Sometimes you feel irritated. Why? I have a malignant disease, and the specialist recommends maybe to not treat it. And some other patients go home and they feel very happy and fortunate, and they make the conclusion, oh, I have a malignant disease, they tell the family, but I don't need treatment. So it can be the one and the other side as an explanation, and very interesting is at all why a doctor can make this recommendation. Because this kind of disease, when the lymph node did grow, it grows very slowly. Sometimes it does not grow anymore. It stays stable in the size of 2.7 centimeters. When you make an ultrasound, you can make an exact measurement. And then maybe 2 years, 3 years, 4 years, the lymph node varies between 3.5 and 2.5 centimeters, wax and wane, as we call it. And then, interestingly, the doctor does not feel the necessity to treat it immediately. Why? Because we don't have absolute and definite treatments where you can eradicate the disease. Maybe you have heard this. So we only want to treat that if the disease really threatens your life, or if the disease really becomes more rapid growing, if the disease is producing suddenly some symptoms and irritations. So some patients really have lymph nodes more or less all over the body, in this region, in this region, in this region. They are all around 2-3 centimeters. But when the doctor asks you, they say, no, otherwise I feel well. I can hardly believe that I have a disease. I go to my job, I play in the tennis club, I go hiking, I go to the theater in the evening, I enjoy my life. I really cannot believe that I have such disease. These patients then probably are the candidates and the patients where the doctors may say, yes, maybe we now make just another period of observation and we do not treat immediately. Some patients still, when you have your common sense, are irritated. They think, the disease is in a such low burden and it's more or less an early phase of the disease. Why not now make a clear and definite treatment? It's a better chance to treat the disease. We don't want to wait until the disease grows. Could be a logical standpoint. And so, of course, when the doctor makes this recommendation, he needs some evidence that he can believe his opinion is true. And this is what you see today, and even Judith will talk about this. This is a thing what we like as hematologists to do a clinical study to find out the evidence for what we are saying. And that is what I was asked to in my very first day of the career, to make a clinical study, because looking for the truth, looking for the real results. This is clinical research and a clinical study. Because when you ask somebody in your neighborhood who has the same disease, he tells you, I have got this treatment and I feel well. You cannot conclude that this is the best treatment for you, because by chance it happened in his life. You need, as you probably understand, to exclude the probability by chance. if you ask the next one, he got a totally different treatment. And if you ask the third person, he got the same treatment as person number 1, and he had a lot of problems. So therefore, you need a critical number of people, maybe 100, maybe 200, maybe 1,000, maybe 5,000. And you know, when it was found out how to best treat diabetes, 70,000 diabetes patients were investigated. And then they can make a clear statement. Now we have looked for a lot of patients and we know what the best treatment for diabetes is. And this makes sense when you make it in such a large group. You find all the small symptoms, side effects, and so on. And follicular lymphoma is not such a widespread disease as diabetes. Therefore, we cannot investigate 70,000 patients. But we would be very happy if we have a clinical study with maybe 300 or 500 or 700. And then also we can conclude something. So watch and wait. Why not treat earlier? And for that, as I just tried to explain to you, we would like to have a randomized trial, a clinical trial comparing these two strategies. Randomized means you go to the doctor tells you, we have a clinical study, I invite you to participate. Here is a clinical trial program. A computer system will randomly assign you to treatment number 1 or treatment number 2. This only can be done if the doctor himself is convinced that he does not know what is a better treatment. If I would know that treatment number 2 is better, I cannot recommend you. But if it's a good question and I think myself, would be good to know what is better, and then it could be done in an ethical way that a random computer system assign you to one or the other treatment. In that study here, watch and wait, you really must randomly assign a patient group to no treatment or to a chemotherapy. That is a big challenge to explain to a patient. So this is the very, very great challenge if you ever do such a study. It was done in the very old days, 1981, and then 23 years later, 2003, the results were published to the community, to the public. Interestingly, you need a very long time and you need some study to find out. This is the only study which is available for that question, and it's an old treatment, chlorambucil. Nobody would do it today. So, of course, everything has strength and weakness. The strength is that it was once randomized. The weakness is that it was done with a treatment nobody is using today. Today we are using much more modern treatment combinations. But still, the one message is very clear. You see how many people survived the disease at 5, 10, 15 years, and you see the percentage in the old days. It's always the same if you get immediate treatment or not. And then what you probably also are used to see are these typical curves. We call them event-driven curves. Always when the curve goes down, something happened, and it could be here that the disease has a relapse, or it could be here because we call it survival, that some patients have passed away, and then also the curve goes down. So the curves could be seen like this. If you have here 16, it means 16 years, and you see that 16 years, 40% are disease-free, or you see at 16 years here, 25% are alive. But this is a very old study. It's not something which you need to know now. But the message was immediate treatment or just make an early phase of watch and wait has no influence on both outcomes. Very interesting. Then the second thing of the study is this curve. And this is a curve which I think is still valid today. That means median time to first treatment, how long it took the time when the first treatment was initiated. 2.5 years was a time until 50% of the patients needed treatment. So this is probably what you can expect. However, this curve means here at 12 years, when you see here, you go here, it's at 18% or so. After 12 years, after 16 years in this study, still 18% of patients have not needed a treatment. And this is still of course, true today, independent of if it was an old chemo or not. This was a patient group who never had a treatment. And this is a solid information. And that is why I still believe when I recommend my patients, maybe there's a chance that the patient is in the group of this roughly 20% who have a very long time without treatment. And if a patient comes to me who is 72, and then I remember this curve, maybe he is becoming 82 and has no needed of any treatment. So that is the reason why we can recommend observation is still a meaningful thing, even if the disease has relapsed after a first treatment. We again think if it's only a small lymph node which is there, we do not need to treat it immediately. So when we decide to treat is listed here. This is more or less a consensus around the world. It may differ from country to country, but if the patient has symptomatic disease and feels not healthy, then we need to treat. It could be night sweat, it could be weight loss, it could be pain, it could be shortness of breath, and it could be that you feel really, I'm not healthy, I feel very ill, I cannot do my normal life every day. Okay, then we start the treatment. Also, we treat the patients when they have bad blood counts, low hemoglobin, low platelets, low number of white blood cells. And the reason for that is typically that the disease is also present in the bone marrow. Maybe some of you have heard and have seen that there is a puncture, a biopsy in the bone marrow here in the hip. Then there inside the bones is a bone marrow, and the bone marrow is producing the cells circulating in the blood. So, if the cells in the blood have their natural death, some of them live 30 days and then they become old and a new cell is coming from the bone marrow. So it's a fluid exchange, always the same. And the disease, follicular lymphoma, can also grow in the bone marrow. Not very rare, this thing. It happens quite often. It's more or less as expected. And if that is growing in the bone marrow to a very extent, it will reduce the normal production of blood cells. And then, of course, you also need to treat, because when the platelets and the hemoglobin goes down, because the bone marrow infiltration is there, then you need to treat to reduce the infiltration in the lymph nodes and in the bone marrow. Also, when the lymph nodes become rather large, then we start treatment, because 2 centimeters, yes, can be accepted, 3 centimeters, okay, but 5 centimeters, no, then we start treatment. And when the disease is growing faster than expected, and when some other complications appear, that some patients feel the spleen or feel pain and so on. So these are the things that we try to initiate treatment. And again, this may differ from doctor to doctor, from country to country, from region in the world to the other region. Sometimes education and mentality and culture in medicine is a little bit different, that the one country cannot accept not to do something against the disease, and some other countries are very defensive and want to stay as long as possible not to be treated. So we have then some recommendations around the world. The highly developed countries like Australia, like Germany, like Europe, like USA have unique recommendations and guidelines. Australian guidelines, German guidelines, and Canadian guidelines. But there's one guideline which more or less is the leading one, because it's always a new version, and the board of members of these guidelines sit often together and discuss what's the best treatment. This is NCCN, it's coming from USA, National Comprehensive Cancer Network recommendations. They exist for all malignant diseases, for prostate cancer, for lung cancer, for lymphoma. And they are very, very detailed. And yes, the highly developed countries have their own guidelines, but more or less the guidelines which are worldwide leading and influencing everything is the NCCN Guidelines. And there you see, for the treatment of follicular lymphoma, you have 1, 2, 3, 4, 5, 6, 7, 8 treatments. When you have an appendicitis, there's only one treatment. Go to the surgeon. When you have hypertension, already you have 3 or 4 treatment options. When you have a follicular lymphoma, you have 8. That sounds a little bit surprising. Why 8 treatments are recommended? Maybe some of them are outdated and the new update will not delete it, like maybe RCVP. Some doctors say, no, it's an old treatment, but it's still good. So it's all under debate and discussion, and therefore also these guidelines have one weak thing. They always are a compromise at the minimal level where everybody can agree in a board of 10 experts. If you have a board of only 2 experts, probably it would be only 2 treatments. But if you have a board of 10 members, you have 8 treatments. That reflects the uncertainty and the way of interpretation of different results in clinical studies. Not necessarily they are wrong and right, but here you see things become a little bit complicated. Then you can see, if you are an expert in reading guidelines, that there is then in category 1, and that is category 2 and 2B. That means a little bit how the statistics is done in terms of quality. If it was a low quality study with only very few patients, then they only make a recommendation 2B. And also, if there was not a randomized comparison of the one treatment against the other, they say it's only category 2, because just making one small clinical study with just one treatment and make no comparison, also that cannot be a good recommendation. So that is first line treatment, and then we have first line consolidation or extended, they call it, and there is a famous Rituximab Maintenance, Rituximab Maintenance, and also radioimmunotherapy. So radioimmunotherapy is rituximab antibody against the disease conjugated with a radioactive compound like iodide 131 or yttrium 90, radioactive labeled medicine. Not done anymore, much too complicated. Nobody is really convinced, but it still stands on the guidelines, because some years ago, yes, it was a recommendation. Why it should be deleted from the guidelines, so it makes confusing the people, but still the experts know, yes, it was a good treatment. If at all we need it again, we could do it because it's still recommended. But the most often thing is rituximab maintenance, and I will address this issue also. So as I told you, we have something where there is a consensus in the world. Watch and wait. As I told you, when it comes to treatment, immunochemotherapy is a standard of care, and immuno means rituximab or obinutuzumab, the monoclonal antibody. So typically an antibody is combined with chemo. NCCN guidelines and the German countries prefer bendamustine plus rituximab as a preferred regimen for frontline, but it also can be given in second line, and also another chemotherapy can be given in frontline. This is my perspective and my view. Then we have the maintenance. I will discuss what is rather new in Germany and in Europe, that there is a new rituximab, because it was only one compound available in the last 25 years, and now the patent has come to an end, and so some new compounds may come to the market, and we call them Rituximab Biosimilars. So rituximab, very similar agents, and then suddenly there will be a little bit of competition in the market, and maybe the price is going down for this very expensive medication. And then you also know that there is a treatment which is called high-dose treatment plus stem cell transplantation. You have heard about this, but this is very, very rarely recommended in low-grade lymphomas. And again, this is a consensus in the world that this high treatment, with high-intensity treatment, does not play a role. We also have something where we have no consensus, ongoing debates in the international community, how to improve the disease when the disease has an early relapse or does not respond to the treatment. We call that refractory. And then the role of rituximab maintenance also is under debate. And the new antibody which is developed after rituximab is called obinutuzumab. And everybody is discussing the question, is obinutuzumab the better antibody compared to rituximab? So rituximab was developed in 1998. Obinutuzumab was developed in 2015, so 24 years later or so. It's a type 1 antibody, rituximab. Obinutuzumab is a type 2 antibody. And in all parts of the world, not in Australia, I learned just yesterday, obinutuzumab is a little bit more expensive than rituximab. So everybody would assume, okay, that's the better thing. It's 25 years younger. It is a type 2 development, not type 1. All the things experienced with rituximab are learned and are implemented in the development of a new antibody. But you also know not necessarily something what is new and more expensive is better. So the things are not so easy just to say it's a modern antibody and it's a little bit more expensive and it's a type 2 development makes the explanation it's better. It's not so easy, unfortunately, or fortunately, as ever you want to see it. And then we have many new treatments in follicular lymphoma. As I mentioned, the new antibody, lenalidomide, idelalisib, ibrutinib, and venetoclax. But I will not discuss them to an extent because they do not play a big role in the routine treatment of patients with this disease. In clinical studies, yes. In multiply relapsed patients, yes. And that is an interesting thing, lenalidomide, because for Germans at least, it's an interesting story. Lenalidomide is a tablet which will come to the market for lymphoma patients maybe in 2, 3, 4, 5 years from now. I don't know exactly. The company will submit it to the authorities and then it will be approved and reimbursed and so on. Lenalidomide is a tablet and it comes from the medication which is called thalidomide. Thalidomide is an old German compound which is world famous, unfortunately, because it made a huge medical scandal, because thalidomide was a sleeping pill for the people in Germany 1960, 50, 70, prescribed by every house doctor for some patients who have sleeping problems. And then, unfortunately, the children were born with a birth defect of the arm and of the legs. And then the medication, of course, was banned and it was closed down in the cellar with 10 doors locked. And the company decided to never, never, never use this medication again. This changed the whole story of developing a new treatment. That is the reason why we do now so many studies, because in the old days, the medication was just developed and brought to the market, and now it has to be phase 1, phase 2, phase 3, phase 4 studies, and all is investigated by the authorities because finding out safety problems. But the thalidomide and then the next compound, lenalidomide, is an interesting story because a doctor from Germany who had some social motivation to help some very poor people in the world went out to a social year in South America. And he went to a camp where the people were with a disease called lepra. What is lepra in English language? Who knows? Maybe Judith, you know? Leprosy. So he went there, and it was a camp with the most suffering people from this disease. And then he thought, how can I help these patients? No treatment is available. They all went to the camp more or less in a palliative intention to have their life the rest of the days and so on. And then he had this idea as a German doctor. Maybe I asked the company who had thalidomide to give it because it's a sleeping pill. And finally, they can have at least a sleep in the night. This would be such a relief. So he asked the company sent the tablets to South America because they thought finally we could do something good with the tablets. And in the end, patients fall asleep and were cured from lepra. By chance. So this happens that this medication now is a WHO, World Health Organization, very important medication because by chance it was found out to be active against lepra. And also it is active against lymphoma. Also, this only came later into the field, and this is all the developments which are here listed on the slide. I will briefly discuss some clinical studies, and maybe you have heard about the words gallium, prima, relevance, or steel trial. If not, it's not so important to learn these terminologies. I just want to show you what was found out. We in Germany did in the year 2003 the comparison of bendamustine rituximab against CHOP rituximab, randomized comparison in follicular lymphoma. And was a very interesting study because bendamustine was available since 50 years in Germany, in the east part of Germany, what was formerly the communistic part of Germany, divided by this wall between the two German countries. And so they used bendamustine, but in West Germany nobody ever had heard the word bendamustine. Because, you know, in the old days we were not allowed to communicate, and the East German people, if they want to write a scientific publication, have to publish it in Russian language, and the West Germans in English language. So we never exchanged any information. After the reunification of the two German countries, the doctors from East Germany came to the West German doctors. Oh, we are so happy. Now we have all this new stuff available from medications. But one thing is good from our side. You know, maybe the chemotherapy, bendamustine. No, we don't know. Oh, this is good. Take it, take it. And then we were very friendly in these days, as always. We shake hands and we said, oh, yes, I will consider it. But thinking was, no, never. Something from the communistic part, oh, cannot be good. So it took a while, 10, 12, 15 years, that we used bendamustine, and suddenly we found out, yes, East German doctors recommended it on the basis of good evidence. It really worked very well. So also this is by chance that this medication became available to the market, and it's despite such an old thing, more than 60 or 50 years old. So also it was criticized more or less by some most senior people. This is a chemotherapy comprising of 4 medications. CHOP means 4 compounds. This is only 1 compound. So also it makes in the first view no sense. Why to compare 1 against 4? Cannot be the same. But of course it can be. Yes, 1 thing can be better than 4 things together. Yes, when you buy a Mercedes with 500 horsepower, probably it's very effective compared to a little Volkswagen. So it could be that 1 is better than the other, even if you compare it to 4 others. Why not? We did this study, and we included the patients in all these different diseases, and then this was the side effects. And the side effects, as typically with chemotherapy, is that the blood cells become lower. White blood count goes down, you have a higher risk of infection, hemoglobin, thrombocytes, which is called platelets, go down. And that happens with every chemotherapy. And with CHOP, it happened in 38% of the cases, and with bendamustine, 12% of the cases. So it happens in both treatments, but less often in bendamustine. That was a good thing to learn. Oh, it has a little bit less toxicity. Second, we also look to the non-hematological toxicity. That is something like neuropathy. Some patients have irritations at the fingertips. Happens quite often with CHOP, but not so often and very minor, if at all, with bendamustine. Some patients with CHOP have hair loss, not only some, but most when you get treatment. And with bendamustine, no hair loss at all is observed. So these are already fundamental differences between the treatments. And then everybody was interested, what is with the efficacy? And the efficacy was that first you look how the disease responds to the treatment. That means, is a lymph node going back, yes or no? This is a quite rough measurement. And you see no difference between the two treatments, 92, 91%. But the most important thing is, of course, not that the disease responds at all, but how long will this response last after the end of treatment? That we call response duration. And this is here again in the curve. Always when the curve goes down, there is a relapse of the disease. and the bendamustine treatment was in our study even better than the CHOP rituximab. So this was very new for the medical field, and that was the reason why I first was invited to Australia in 2014 to discuss this kind of results in the country. We then did a very long observation, 10, 11, 12, 13 years after the treatment, and you still can see that the bendamustine had a better long-term disease control than the other treatment. However, it did not translate in an improvement of the survival expectancy because, as you may know, when the disease comes back, you have opportunity to have a second treatment and a third treatment. So it was no survival differences in the end, probably because all patients who were treated with CHOP and have then a relapse of the disease were then treated with bendamustine. And then, of course, they again had this good effect of the bendamustine treatment. So the big information was bendamustine can be integrated in the armamentarium. If it was first or second line, it helped the patients at all. Then we have the question of maintenance, rituximab. Again, a very famous study, which is called PRIMA study. 3 different treatments were given for the first 6 months. And all patients then who responded to the treatment, 85% were randomized, 1,000 patients between no further treatment, which is a standard of care, 6 months of treatment, or 2-year rituximab maintenance. 2-year only rituximab, no chemotherapy, which is a monoclonal antibody. 2-year long every 2 months. So it could be that you go to the hospital every 2 months for 2 years to get another infusion. By chance, 50-50%, and the disease control was better with 2-year treatment after the chemo than no 2-year treatment at 2 years. So on the basis of this, the world authorities accepted that rituximab maintenance is meaningful for the patient with that kind of disease, and it was approved. Then everybody hoped, that hopefully will translate into a survival difference. But it was the same overall survival. But you see, the curve after 2 years was very high. It was in the range of 90%. How can you improve a 90% curve so easy? So everybody said, yes, we know follicular lymphoma needs a very long observation. This is just too short to find out. 10 years later, as we did in our study, after 10 years here, the disease control with maintenance is still much, much better. But 10 years after the treatment, still the overall survival shows absolutely no difference. You hardly see a difference between this. But these are 2 curves always. Only here you see green and blue. So that is a little bit disappointing because this is not a one treatment versus the other treatment, like bendamustine against CHOP. This is 2-year treatment versus no treatment. And then with a 2-year treatment effort, at least you expect that you have a huge benefit of a 2-year treatment. So therefore, the maintenance treatment is sometimes under discussion. It is good to make a longer disease control by 2-year treatment, or it is not so important because anyhow, you have more or less the same life expectancy because when the treatment comes back, then you will be treated again with a rituximab-containing treatment, and in the end, you have the same perspective. That is a very interesting question, and there is no perfect answer for that. Some patients in my clinic absolutely want the maintenance treatment because they feel the disease was not eradicated. I still have it. I want to control it with medications. I want to have this infusion every 2 months to maintain the treatment success, which means maintenance, to have a longer disease control. And some patients say, I don't want to go every 2 months to the hospital. I don't feel comfortable. I always have this memory of these patients and so irritating for me. And always after the infusion, I feel irritated and sick for 1 week. I feel exhausted, I feel tired, I cannot enjoy my life. Probably, not probably, both are right. So one experience and the other experience. But because it was not a definitive survival difference, I, as a doctor in Germany, are very happy to accept that we can have the two options. If the patient says, I don't like the treatment, it would be 2 years with maintenance, I'm absolutely happy because I know, yes, treatment results speak for this. And if patients say, but I have anxiety, I feel so nervous that the disease may come back early, can we not do anything? Then probably it's a good thing, yes, we treat it and we continuously try to keep it under control, and that's a good reason to make maintenance. Some doctors in the world are very principled. They say maintenance, absolutely. Some doctors in the world say no maintenance, we don't need it. Some doctors are influenced by the economy situation in the country. When a country does not have so much money, they say no maintenance. Some countries which are very, very rich and have a business interest in medicine, like United States, they say all maintenance. United States is different. United States more is a business to do medication. This is not immoral in United States. You know, people in the United States have sometimes a different perspective, and it's business. Yes, why not, they say. Don't ask, it's business. We make good business that you live longer and you have to pay and it costs all money and so on. So why not give maintenance? So it's very different based on cultural influence, pharmacoeconomical influence, and interpretation of patients' expectation and of doctors' interpretation. I will show you also one more study to show you the dilemma of this question. And also, of course, what you know when you are no expert, when you are be treated with 2 years and the other group has no treatment, guess who has more side effects? The patients who are treated. And yes, observation, 57 against 38, 24 against 17, 21 against 13% have a little bit more side effects, which is quite normal because you get 2-year treatment. And the main thing is that the immune system will suffer from a 2-year treatment with rituximab. Because rituximab is good against the disease, unfortunately, it's also bad and effective against the normal and healthy immune system. So when you continue to treat, maybe you have some more infections than the other patients who have no rituximab maintenance. This has to be outbalanced in terms of a better disease control. So then one question arises on the community, and Judith knows everybody discussed. Maintenance was better after the CHOP. BR was better after R-CHOP. Why not combine maintenance with BR? So you can say, oh, it's just a matter of principle. When maintenance was good after R-CHOP, it's also good after BR. And if BR is a better treatment, we make combination. Things are not so easy. You cannot just combine it like in a cooking recipe, yes? A little bit salt, a little bit sugar together, and it's a good taste. No, it's not. You have to make your statistics and your experiment. Is it really good to combine bendamustine and maintenance? Nobody knows, but most countries did it. I, in Germany, who was more or less the most convinced doctor about bendamustine, was not convinced that maintenance is good. So I decided, yes, let's do the clinical study. We did the clinical study. Unfortunately, in 2008, we asked the wrong question. Why? We asked the question, all patients with follicular lymphoma are treated with BR, and then all patients are treated with 2-year maintenance, and then after 2.5 years, we are randomized to 2 more years against no further treatment. So this is in the end the question of 4 years against 2 years. This was not my idea. I wanted to do 2 years against no treatment. But the German doctors in 2008, 10 years ago, were all highly motivated and highly fascinated by this idea. Maintenance is the best treatment. You know, 10 years ago, it was more or less new, and when something is new, everybody has this fever of that is new, like a new Hollywood movie. You have to go. It's a new treatment. You have to do. So the doctor said, Professor Rummel has a good idea. It's a scientific good idea. But in real world, we would not accept the study by doing no maintenance. So I had to sit down and to think along. Maybe I had to go hiking to the mountains. Shall I make a democratic vote? And 85% of the German doctors say, no, we will not do it. And then the study will not be done. Or will I move myself forward to the expectation of the German doctors? So that is the reason why we did 2.5 years and only randomized them. I was feeling 4 years of maintenance is too much. I could hardly believe that somebody goes 4 years to the hospital. However, you can think patients want to do it. When they tolerate 2 years and suddenly it comes to the end of the 2 years, they ask me, why we stop now? I feel so good. Disease is in response. Maybe I say disease would be anyhow in response. They don't believe. It was rituximab. I want to continue. 4 years, 5 years, 6 years. Swiss colleagues in Switzerland made 5 years against no maintenance. And there were some ideas to do maintenance without any end. Could be, why not? You could make it, who knows? But it was not done. Sometimes it's not only a question of toxicity, but also of financial toxicity. Yes. So this is just a theoretical idea. So 4 years against 2 years. This is a result. Disease control. PFS, the difference is there, but what the experts know, if this p-value is higher than 0.05, doctors and scientists do not believe that this is a real treatment result. It is more by chance, more. Of course, I think, yes, there is something like a small effect, but it's not evidence grade 1. This is what you learn when you do science. So it's a result which looks better, but indeed is not really better. So 4 years was, we call it a little bit better than 2 years. And in the overall survival, you see both curves are very high. This is 2.5 years after randomization. So this is 7.5 years here. And you see where we are. This is only the patients who made the randomization after 2.5 years. So it's a positive selected patient group. It works. So we could say 4 years is not better than 2 years. And now the question comes, is 2 years better than no maintenance? So we did this. I just want to make one more statement because before I come, immune globulin is the immune system and CD4 is the immune system, 2 parameters. And they go immediately down when you treat. This is always the bad side of the coin when you start the treatment. And even the immune system here goes down after 6 years, even if you only have done 2.5 years treatment. So really, the immune system is very much harmed by the treatment. This needs to be accepted more or less. You cannot do something against it. And this is the bad side of the coin. But it can be managed. Therefore, you go every time to the doctor. And you know already as an education, when you have some infection, you have to go to a well-informed doctor. Now comes the question, 2-year maintenance after BR. We have not done a direct comparison. You already learned what I want to say. It's not a randomized treatment. It was the one in 2008. We all took the patient with 2 years and compared it to the old from 2003 study. And we could do it because it was the same doctors, the same study groups, the same protocol, inclusion, exclusion criteria, and treatment algorithm. So more or less, it's not the very best, but it's good enough to give some idea to the doctors around the world. It is worth to do it, yes or no. So I was sitting there in the August, I know exactly as today, and I had no idea what will be the result. And I had to write down the little paper to communicate to the world, to the big meetings. And this doctor came from the statistical office from my study group. Here's the result. This was the result. 2-year maintenance, is better than no maintenance. Personally, I was totally surprised. I have never expected this. Absolutely not. So I thought about for 2 hours. No reason to say that it's not better. It was better. Even if it was not a direct comparison, that would be the message. But I told you, I'm not so quite convinced about the maintenance. I then thought this is rather compelling. However, I asked my statistician, now show me the most important curve, the overall survival. And this is the overall survival curve. As always, you sit down and you become smaller in your chair. Oh, it did not make a big impact on the one and only effect what you really want to see. So the overall survival was not different, more or less. So it was a little bit, as always, in the same story. I presented this result in front of 3,000 experts in America at the World Meeting for Hematology. And we have 6 presentations in 90 minutes. And they are the best 6 presentations for this kind of disease. I was elected to go on the stage to speak. I showed these curves. After the session ends, the speakers always sit in the first row because they want to go very fast to the stage. And some of the audience is coming to the first row after the end. And then you talk nicely to the colleagues. Somebody comes like Judith from Australia. I say, oh, Judith, good to see you. And she says, good talk. And so we talk to each other. And the one colleague, most famous from America, USA, immediately came to me. And he took me in his arms. Matthias, I love you for this study. You know, we all waited for your results. I'm so happy that you showed it. Now we know rituximab maintenance can be given after bendamustine. He kissed me 3 times. He congratulated. He went away. The next doctor from United States, worldwide expert, was there, also congratulated me, took me in his arms. This is brilliant. Finally, we know we do not need any maintenance. That happens by the worldwide leading experts in 30 seconds. So you see how different the results are understood. And therefore, I have to say, it's case by case and individual discussion if you really think that the maintenance treatment is a good treatment or it's maybe not a good treatment. And I had my last patient, he told me 68 years, wealthy man, stopped his job in a bank. He said, I want to play golf until I die. I don't like maintenance. I have another patient, young, and he said, I want to build on my career. I want to be very fit in the next years. I want maintenance. I tolerate it well, but then I stay longer in a disease-free phase. So, yes, both are probably have the right perspective, and as a doctor, I'm happy to do this. I don't always say to the patient, it's your choice. I don't always say, I'm not convinced that this is a good thing. I studied medicine for 6 years. I studied internal medicine for 6 years. I became a hematologist. I go to all meetings worldwide. I think patient expects some guidance. I don't say, now this is the result, go home, make your choice, come back, I give it to you. No, but here, in this situation, I'm happy with both things based on individual life circumstances. So then, this was our conclusion, that with the limitation that it was not a randomized BR can be further improved by the maintenance in terms of disease control. We then have another study for which the world was waiting, the new antibody, obinutuzumab. And maybe you know this study, gallium study. These are the authors, and you can find immediately that there are 2 Australians there, Stephen Opat and John Seymour, and that means that they have contributed to the study a lot. And the one here from England was the first presenter, and one colleague from Germany was the last author. So you can see when you are an expert how many countries were involved. The one man from Czech Republic, And so it's a quite very international approach. This is a pharmaceutical study. This is not a study run by a doctor by himself. And this is in order to get a new medication registered to the market. And the new medication is obinutuzumab. Obinutuzumab, this is rituximab and chemo, and this is not O plus chemo. I was wondering why they say G and not O. So it's a little bit not logical. Always it's the first letter how the compound is named, obinutuzumab. First, there was another antibody, which is called ofatumumab. Sounds very similar. And this was bendamustine plus ofatumumab. Second, everybody laughed in the audience when they say BO is not a good name for a combination. I never understood why people laughed. And then I asked her, why are you always laughing if somebody is saying BO? So this is probably, when I understood then what is behind this word, the reason why this is not a good abbreviation. Also because of the ofatumumab. Therefore, always with a G is being meant obinutuzumab, and G stands for the trade name Gazyvero. It was R chemo against obinutuzumab chemo followed by maintenance. And then again, response rates. The same, but you already have learned maybe response rate is only a short look at the results. The most meaningful is how long does the response last, and this is response duration or disease control. We call it progression-free survival. The red curve is better than the blue curve. Second look by an expert would be what is the p-value, and it's smaller than 0.05. So the results are true, they are real results. Red is better than blue, and red was the obinutuzumab containing treatment and blue the rituximab. However, when I was sitting there in the audience and I saw the results by Robert Marcus, I realized that all doctors in the it was 10,000 people audience because it was a plenary session. I realized when looking to the right, to the left, everybody was, because we expected a bigger difference. We hoped for a much more relevant difference. It is a difference, but it appeared rather small. But it was a true difference. It was slightly better, very clearly. And that was how the treatment was designed for, that you have a better disease control. And yes, again, as the old story always is repeating, when it comes to the overall survival, this did not have an influence. So again, yes, it already becomes to start, a debate. You have this one better, but in the end, the other parameter not better. And then you have the side effects. And then you want to see the side effects. And then you see rituximab against G, and you have all these different parameters. All for experts, what's happening. But then you see here, have a look, the obinutuzumab has 74%, and this is 68%. And when you go to the next side effect, you see 44 against 38%. And then you see 6.9 against 4.9. Each thing is a little bit more toxicity and side effect than the other arm. It's not very critical. But when you see the whole picture, every single thing is a little bit more often in the obinutuzumab, then you see the story, okay, it is slightly better, but it is slightly more problematic for the patient. Probably you do not realize because you would be the patient who has no side effects, but probably you are a patient who has side effects. And this is therefore never, never, ever an individual-driven decision. But at least from the message, the one treatment is a little bit more effective and on the same side, a little bit more with side effects. And then that was also then the conclusion. It was an improvement, but also higher rates of side effects. And then last slide, very important, chemo-free. This is the big advertisement. I always was sitting in the audience when the first people and colleagues were on the stage and said, now we develop a chemo-free regimen. What does it mean? Chemo-free, no chemotherapy. And here comes the lenalidomide. I told you, which is the next substance after thalidomide, here now was studied that it's also active in lymphoma. But chemo-free is a very rhetorical and suggestive word, because everybody immediately would believe it means toxicity-free. This is what probably you should understand when somebody says chemo-free. So I was always critical about this word chemo-free, because it does not tell you about that you can avoid the toxicity of chemo, but we will see. So it was 2.5 years treatment, the typical thing, 6 months are chemo plus 2 years maintenance, or 1.5 year, the combination of the tablet with rituximab and 1 year rituximab, which is also in total 2.5 years. Lenalidomide is given 3 weeks, 1 week off, 1.5 years, 21 days taking a tablet and 1 week no tablet. And this is the result. Response rates and disease control are superimposable. So it was a disappointment or a good result. It was a disappointment for the company, because the company wanted to find out that the chemo-free is better, and then TGA and FDA and European authority would accept lenalidomide as the best treatment and would be coming to the market. But it was not better than chemo, so it could not be accepted by the authorities. However, it was a brilliant result. Chemo-free means at least as effective as chemo. So clearly, it is a good message that something new has been brought into the field of medications, and the response rate and the disease control and the overall survival is the same. And then it came to the toxicity, and this is the toxicity. When I saw this slide, my very first impression was, what is which side? You cannot see a difference. It's more or less the same. I mean, in summary. Of course, there are small differences. In the one here, rash, more skin irritation, here less. And here you have more the neuropathy in the chemo, but less here. But in the most effective neutropenia, it's the same, more or less. There are small differences, but this is no chemo, and this is chemo. So I also have concluded it's not just an easy thing to make non-chemo. You also have side effects as with chemo. And this medication will be available, I believe, despite the fact that this study was not showing a very good result, in relapse disease soon. There are other studies in the second line and third line disease, and then it was positive, and it is submitted to the world authorities around the world. Lenalidomide plus rituximab probably in 2, 3, 4, 5 years from now will be available as a second line treatment. So in summary, I tried to introduce to you watch and wait is still meaningful. In our opinion, bendamustine plus rituximab is a good treatment. Maintenance can improve the disease control. Obinutuzumab was slightly better, but also slightly more toxic. Obinutuzumab is a good antibody when rituximab does not work. I have not shown you. High-dose treatment and stem cell transplantation does not make sense. And chemo-free is comparable to our chemo with different side effects. And the new agents like here, ibrutinib, venetoclax, and idelalisib still are not having a valid role in this treatment. So this was my slides, which I wanted to introduce to you, and I hoped and I could see at least in some faces that you could understand my words and messages. So therefore, I thank you so far for your attention, and I'm very happy to then continue after Judith has shown you her messages to have a good discussion of some questions. You have a computer?
Thank you very much, Matthias. While I'm putting mine on, in fact, let's just go back to one really important slide. Right. Is this slide? All right. We are now in an era where with the very effective antibody chemotherapy treatments, even, especially for the patients who've been watched and waited for a long period of time, where their survival is starting to approach patients who have not been diagnosed with follicular lymphoma, where people are living, if you're diagnosed at the age of 68 or 70 with your follicular lymphoma, and what's that, let me do the maths, 5, 6, 7, 8 years out, your probability of survival is 85%, I hope these are really powerful messages that we're getting on these overall survival curves about, the prolonged survival, median survival. Obviously, there's a range for patients with follicular lymphoma. Do you want to add that on for me? That'd be fantastic. What I thought you might want to do is all just stand up for a moment and stretch your legs for just one moment. Okay. Because I was going to let you have some questions after Professor Rummel talks, but then I realised all those studies he presented actually give a great segue to my talk about the Pi3 study and the clinical trials that are available here in Australia. So while your mind is bursting with all that data, it starts, I think it says patients.
Patients 2019.
Yes, that's the one. Thanks. I thought we would quickly whip through some of that. And so feel free to stay standing or else sit down once you feel you've got the blood flowing again. And I'm very, very proud of the fact that just about every trial Professor Rummel presented at Concord and around Australia, we contributed patients to the PRIMA study. I don't want to out any of you, but I wouldn't, based on the numbers of you that are here, I wouldn't be surprised if there are a few of you who had actually been participants in the PRIMA study. In the gallium study, I'm sure there are a few of you who may have been participants in the gallium study. And even the relevant study, even the study comparing the chemo-free regimen, we had 3 patients. We opened the study about 2 weeks before it closed. We opened it at Concord Hospital, the only site who was able to get it open in Australia. And I remember one of my patients, and he's quite happy to be this to be publicly declared, is a professor of anaesthetics who was up in the Gold Coast giving a lecture, and he was ready to an emergency medicine. He works for CareFlight, and he was ready to be enrolled in the relevant study a week later. We had everything lined up, and then overnight I got an email from the French saying the study is closing tomorrow. And I thought, oh, this is one advantage. We're a little bit ahead in Australia. And I rang him up and told him, you've got to get on a plane and come down and sign right now, sign the consent form today, because the studies are closing tonight. And so that's what he chose to do.
I want to make a comment on this. That happens, unfortunately, very often, that we make these huge efforts to open a clinical trial. The same happens in my centers. I do a lot of work, and suddenly administration process and the contract between the companies and the hospital and the doctors and the ethics committee all takes so much time. And what is the interesting thing is that I realize the study is closed. Why? The study closes when Judith has it opened on the last day. Who made the patients, if not Judith? China, Turkey, Malaysia, Indonesia. They're all happy to do the study. They make it fast and quick. And that is why I see a risk that the highly developed countries are falling a little bit back when they make the things so complicated that they stand themselves in the line, They cannot come forward because they make a little issue out of such a little sentence in the contract. I discuss with all my lawyers. My lawyers are so strict with this contract. I told my lawyers, you can close the discussion. I asked my lawyers, what are you going to do, Mr. Lawyer, when you fly to Europe, you arrive in Rome at the airport, you go to the car rental company, and some lady sits behind the desk and tells you, I make here 4 crosses and you sign. And the lawyer will sign immediately. He will not read the contract.
No way.
And the contract comprises of 28 pages written in such a small format. The lawyer has no interest to read because he wants to get the car. I say, I want to have the study. Please don't read the contract so much,
I'm not quite that bad. Oh, but we do. And you know, it's a credit to Matthias, his stamina in getting so many trials through. All right, so let's whip through a couple of things, but I just want to stress this is so important. And when you think that, you know, if you feel really confused about what is the best treatment for follicular lymphoma, all right, just remember, it's not only the type of lymphoma you have, it's not only the physician who, by the way, is not an autocrat at Dr. House, all right, but a multidisciplinary team setting who's making that decision. It's your wishes. It's your priorities, your comorbidities, your age that really comes into play for the decision about the treatment of your follicular lymphoma. So that's why you have to be really, really careful comparing why you got some treatment versus what another patient got. And I really do, you know, you can tell that both Matthias and I are clinical trial enthusiasts, dare I say zealots, all right? But even us as enthusiasts, we say every patient should be screened for a clinical trial, but not everyone should be recruited, all right? And that's a key difference because the clinical trial might not be right for you. And we'll talk about that in a little bit later. But what I think is absolutely important that you as a patient in Australia should be asking and expecting now of your doctors is that there is multidisciplinary team review, peer review of your therapeutic decision and the recommended approach that your doctor is making for you because of the complexity of treatment and because this is a really important life decision for you, whether you're receiving first-line treatment, whether you're being watched and waited or recommended to be watched and waited, or whether you're having subsequent lines of treatment. All right, so let's have a little talk. You've already had the talk about the chemotherapy approaches, the sort of weapons of mass destruction, but I do like to think that our research is moving us away from blunderbuss chemotherapy. We are moving away from absolute chemo, and clearly the thing that has transformed the prognosis and the survival and the quality of life of patients with follicular lymphoma in the last couple of decades has been the introduction of rituximab to chemotherapy. You've already heard about the use of obinutuzumab, the next generation anti-CD20 antibody, and CD20 is this protein on the surface of the cells, and the antibody attaches. It's very targeted to that protein, so it helps trigger off a multifaceted reaction that kills the CD20 positive cells, which kills the lymphoma cells, but unfortunately also kills the healthy B cells in your body, hence the additional toxicity. The immune system regulators or modulators, the lenalidomide is what's that R, Revlimid, and R squared that Matthias was talking about in the relevant study is the combination of rituximab with lenalidomide, the so-called chemotherapy, but certainly not toxic-free approach, as I have had experience with lenalidomide in our clinical trials. And then we've got all the enzyme inhibitors, you know, and we are starting to be clever. We are moving away from the classic, just this classic cytotoxic chemotherapy. But unfortunately, they have their own toxicities. And certainly these Pi3 Kinase Inhibitors like idelalisib, they're approved in Australia for people who have had multiple relapses because it has, yes, it is effective, but yes, it has significant toxicity. Likewise, ibrutinib, and you may have heard Greg Hunt talk about the announcement of ibrutinib for the treatment of chronic lymphocytic leukemia, for the treatment of mantle cell lymphoma. My WM patients are desperate to get it approved for Waldenstrom's. But we did a study, the DAWN study with ibrutinib, and only 20% of patients actually had a good response to ibrutinib in our follicular lymphoma study. So it is not the wonder drug for follicular lymphoma. And while we are doing the studies with what's called BGB-3111, zanubrutinib, I think it's going to be a bit better, is my prediction, than ibrutinib, but I don't think it's going to be a lot better. I don't think these bruton tyrosine kinase, these protein inhibitors, are going to be particularly effective with follicular lymphoma. Similarly, venetoclax, all right, and again you may have heard of Venclexta, venetoclax, the great wonder drug that was developed over 2 decades of good, hard, systematic laboratory and clinical research down at the Walter Eliza Hall Institute in Melbourne. That has actually been shown to be very effective for chronic lymphocytic leukemia, for mantle cell lymphoma, again, despite the fact that it targets this BCL2 protein that is overexpressed, this sort of cell survival, this sort of protein that engenders sort of immortality to the follicular lymphoma cells. Although it targets that protein, surprisingly, the results, wouldn't you say, Matthias, with venetoclax have been a little bit disappointing. So watch that space. I just want to remind you again of the terminology that we use, and I shouldn't really probably be a bit pessimistic of me to start with refractory disease. When your doctor talks about your disease being refractory to therapy, that actually very rarely happens in the first line setting with follicular lymphoma. Follicular lymphoma usually melts away with first line treatment, but it does become commoner as you have second line, third line and subsequent lines of treatment. When your doctor says, good news, your disease is stable, well, this might be not such good news because it means that it hasn't got any more than 50% smaller in terms of its volume. A partial response is a 50% reduction, and a complete remission, that temporary parameter that is often that we use as one of the endpoints for clinical trials, is where we can't see that lymphoma anymore, whether we do a CT scan, a PET scan, or a bone marrow biopsy. And it's only time that will determine if you are cured. And I might be a bit of a heretic using the word cure in a talk about follicular lymphoma. But I think we really need to rethink, and I want you to interrupt here, Matthias, and tell me what your impressions are. We actually need to rethink about what cure is, all right? Because, Max, if you die at the age of 85 with your lymphoma in remission, is someone going to say, he died of an incurable disease? No. All right. If you can continue to live well without your lymphoma relapsing, or for its, it really challenges the therapeutic nihilism we used to have about follicular lymphoma in terms of it being an incurable, multiply relapsing disease. But certainly, if we are going to find an ultimate cure, because certainly the patient who's 38 diagnosed with follicular lymphoma instead of the patient who's 68 diagnosed with follicular lymphoma is going to have a far lower chance of a functional cure of their follicular lymphoma. I think if we are eventually going to advance to a curative approach, we are going to need to have patients obtain a complete response, a complete metabolic response, and a complete molecular response. And the Germans are leading us in the world. Christiane Potts, is she at Kiel in Germany? Are leading us in the world in terms of molecular minimal residual disease monitoring. Relapse and progressive disease are pretty self-explanatory, and already Matthias has spoken to you. If you want to understand more about your follicular lymphoma in the different trials, progression-free survival is that duration of the response of keeping the disease away and you staying well and alive. Just remember, all right, we are all impatient. But the most important thing about clinical trials is the fact clinical trials are not just about efficacy, all right, how well a drug works. The most important thing for clinical trials first is safety, all right? And after the preclinical research, after the animal research, the phase 1 clinical trials are really important to determine whether a drug is safe to use at gradually increasing doses, all right? After that early study in patients, particularly in, say, follicular lymphoma, the phase 1 trials are usually conducted in patients who've had their lymphoma treated quite a few times, and there's no obvious, therapeutic solution that I can, get from the PBS for that lymphoma. It's really done first to see if it's safe to give, and what is the ideal dose to be moving on into what we call phase 2 clinical trials. Now, phase 2 clinical trials, they assess safety as well, because they're assessing safety in a much larger cohort of patients. So we're going to detect the less common side effects. But also they're starting to look at efficacy, how well the drug works against the lymphoma. And then it's the phase 3 clinical trial that compares the new drug, the new therapeutic approach, which might be giving less chemo rather than more chemo, changing comparing one dose of the drug versus another, drugs in combination, PET-adapted approaches. Those phase 3 trials are what we call the randomized controlled trials, where you're comparing what is the standard approach with the new proposed therapeutic approach to see if it is superior. Now, I was on ABC Radio just on Tuesday, a Focus with Cassie McCulloch, right? And one of the biggest misconceptions that I think Australian patients have, and I suspect Germans as well, is that, you know, they're worried when they're enrolled into a phase 3 trial that they'll get the placebo, okay? It would be entirely unethical for us to do a phase 3 trial using a placebo unless a placebo, or what we call observation, no treatment, was the standard of care, okay? So you will only get a placebo in a clinical trial if that was standard of care, all right? Or a placebo in combination with standard of care. So that's a really important misconception to be addressing. No ethics committee would ever allow that to be conducted in you. And I want to remind you about post-market surveillance, all right? Because as Matthias talked about, it was post-market surveillance that identified all the congenital abnormalities with thalidomide. And this is William McBride, the Australian gynecologist who first noted this, who was subsequently discredited for his own research misconduct. But post-market surveillance is what identified all the cardiac death associated with the Vioxx, the pain medication years ago. It is really, really important that we monitor drugs even after they've been released into the market. So what is a good clinical trial? It's one that asks the right question and one that reflects your values, all right? And we always have to appreciate that industry trials, they have an agenda. It's usually about, how they can get the drug to market, all right? And we appreciate and we participate in those clinical trials if we think the objectives of those trials align with the objectives of our patients, okay? But what we would much rather be doing is running our own investigator-initiated trials across the board. But in the end, investigator-initiated research is incredibly expensive, incredibly time-consuming, and this is why industry generally only has, well, not only has, but generally more commonly has the funds to conduct large trials. But certainly through your taxpayer money, through your Medicare, $7 rebate to the Medical Research Future Fund, we're going to be seeing an explosion of investigator-initiated clinical trials in Australia. So you make sure you vote hands off our MRFF in the coming election, okay? Because it's about to become quite a big fund for clinical research. So what else is a good clinical trial? As I said, it's got to be ethically justifiable. It's got to be conducted ethically. There is a code of good clinical practice that came out of the Nuremberg trials after World War II. And it's got to be asked a question that can reliably be answered. All right? There's no point asking a question with 100 patients in the trial if you actually need 1,000 patients to reliably answer the question. It is unethical to conduct an underpowered clinical trial. So this is sort of what the formal definition of a clinical trial is, and it really pays to sort of understand that. It's carefully designed. It's conducted under this code of good clinical practice, and it seeks to determine under a very controlled, monitored environment the safety and the effectiveness, all right? Please remember safety and effectiveness, not just effectiveness, of a new therapeutic approach. Why would you participate in a clinical trial? Clearly there's the direct benefit to you from that studied therapy, and the direct benefit to patients even when the treatment is standard of care. And there's been very good data that's come out over the years repeatedly that shows that patients who participate in clinical trials have better outcomes. You have your own study coordinator who makes sure that your treating physician is jumping through the hoops properly and correctly for you, and that the protocol is being followed, although the protocol can always be violated in the interest of your safety. Obviously, there's the benefit to medicine and science and to future patients, but certainly a driving factor for many patients is the access to therapies that have already shown great promise that are not yet available through the Pharmaceutical Benefit Scheme and publicly funded here in Australia. And I had one of my medical students do a pharmacoeconomic analysis of the value of medicines that were received by our patients at Concord Hospital in clinical trials over the last 6 years. All right? And he found that more than $20 million worth of agents that were subsequently approved were accessed through the clinical trials. So that has a huge, economic benefit as well as, personal benefit to patients. But why wouldn't you participate in a trial? All right? You've got to, when you read that consent document and when you go through that whole quite often prolonged process of informed consent and discussing the trial with your treating physician and the investigator, is it might not be quite the right question for you, all right, at your time and your journey with your disease. The direct risk must be acknowledged. It's usually quite quantifiable, but there is always a risk. It's easier just to say, doctor, just treat me the way you think I should be treated. All right? And often it is a bit too much for patients to think about. Matthias talked about how the lawyers have given us 28-page consent documents. They're, really quite overwhelming when you, a vulnerable patient, are often at a point where you're quite unwell and you need to have treatment. And it certainly generally requires more blood tests, more visits because of the rigorous monitoring. And you do need to ask the question, what is the benefit of this trial to me, to the investigator, to the study sponsor, and to patients in future. But nonetheless, we need to counter negative public perceptions about trials. It's why we call our clinical research unit our research unit rather than our clinical trials unit. Because unfortunately that word trial, although it's very much well accepted by the likes of Matthias and I think there's still a little bit of public suspicion of the sort of the human guinea pig approach, which is, to me, is quite unjustified in this world of very rigorous research ethics and governance. I just want to briefly mention to you, anyone who wants to take notes, of ClinTrial Refer, which is a mobile app that we developed now 4 years ago, and you can download it on your Samsung or your iPhone. And what it does, it has a very easy to navigate listing of all the currently recruiting trials. So if you download ClinTrial Refer New South Wales Hematology, which is our very first app of about 22 now, you can actually go and search under follicular lymphoma, and I can tell you right now there are 16 different trials being conducted for follicular lymphoma. And as a result of that app, we had a 9 times increase in cross-referral of patients of New South Wales. That's why sometimes your haematologist will tell you, no, I think the best treatment for you is not here, but down the road at North Shore, up the road at Westmead, because of this particular clinical trial that I think you should be screened for. And the Department of Health have finally giving us some funding support for this, and we're going to roll out version 2, which is going to cover all trials across all disciplines in Australia, and as you know, it's freely available to download. I'm not going to quickly zip through PET scanning because we have really gone a little bit over time, but I just want to show you some details about the Petrea study. And maybe we can save this talk if anyone wanted to do it online. I'm happy to do this talk as a separate webinar one day for you, Sharon. But this is a patient whose lymphoma remained after having 6 R-CHOPs and 2 rituximab, and then they progressed 6 months after maintenance. I'm going to go past all this stuff, but simply say that basically as the result of some research that I and others have done over the past decade, PET scanning is now the standard staging and response assessment imaging modality for patients with follicular lymphoma. Not just a standard CT scan, but a PET CT in combination. And it took us a while to get these studies done because there was obviously no big pharmaceutical company interest in doing so. But I want to tell you about the Portrea study because we've opened that just this month here in Australia, and many sites across the country are going to be opening Portrea for patients who have previously not received any treatment for their follicular lymphoma but are now in need of treatment. And this is the study schema. So the patient who requires first-line treatment is going to receive, have a baseline standard PET scan for staging, and then they're going to receive their rituximab and chemotherapy, all right? And the chemotherapy can be bendamustine, it can be CHOP, it can be CVP. It's very permissive as to what chemotherapy is allowed. Similarly, we're going to allow obinutuzumab antibody. All right, we're not going to be too fussed whether investigators use rituximab or obinutuzumab, but that's coming in a protocol amendment. Because in the end, it's not about how you get there. What this trial is studying is the role of the PET CT at the end of your induction antibody chemotherapy treatment. And what this trial is, it is two separate trials, two separate approaches. In the patients who become PET negative, who will be the vast majority, about 85% of patients. So if you've seen your own PET scan and you see how the lymphoma lights up like Christmas tree lights, all right, all those lights will be off at the end of your treatment. And the patients who are PET negative are going to be randomized. And this is why industry didn't really particularly like this study, and this is why it has to be an investigator-initiated study that we are conducting with the British. We're going to randomize, toss of a coin or computer-generated randomization, to rituximab maintenance compared to no maintenance. So what we're doing in this randomized part of the trial is we're going to measure for the patient who becomes PET negative, because we know not just is their progression free, but their overall survival is so good. What is the trade-off of the rituximab maintenance in terms of that progression-free and survival advantage versus its infectious risk? Okay, so we're working out the trade-off between toxicity and disease-free duration. And in the patients who still are PET positive, so the Christmas tree lights have dimmed but are still shining and they're still a little bit hotter than the glucose uptake in the liver, we're going to give them a separate randomized trial, all right? And they're going to get rituximab maintenance because we know these patients who are PET positive have an inferior progression-free survival, 5-fold more risk of progression, and a 5-fold more risk of dying. So we know this is a bad group. It's a small group, but it's a bad group of patients. So rituximab maintenance is a natural thing to be offering them because we want to prolong their progression-free survival. What we're going to do is we're going to offer them rituximab and lenalidomide, the so-called R-squared approach, as a randomized question. So half the patients will get rituximab maintenance and half will get rituximab and lenalidomide to see if we can, get the benefit of adding in the lenalidomide, the immune modulatory therapy that already has been shown to be neck and neck with our chemotherapy in the induction approach. So we're looking to recruit 840 patients globally, which will take us about 5 or 6 years. And with obinutuzumab added, we'll have to increase the number to about 1,000 patients, which is why we're talking to the Scandinavians and we're talking to the Germans and we're talking to people around the world because we'd like to make this as global a trial as possible and recruit as fast as we can to answer this question and improve the outcomes for all patients with follicular lymphoma and to start effectively doing an individualized treatment response adapted approach. And with that, I'm going to stop there because I don't think there's probably much more that we should do. And I think what we should do, Donna, is actually if people wish to stay beyond 3 o'clock, I know the official closing time was 3 o'clock, wasn't it?
We started a little bit late.
We started late, so yeah. But you know, people, you've all got busy lives. You're out there living your life. If you have to go, just go, all right? That's absolutely fine. And we'll keep going for at least another 20 minutes or half an hour with Q&A.
Good 20 minutes,
Yeah.
Sure.
Okay.
Thank you so much.
No problem. But if I could also encourage Nikki and all of you to be out there and promote the Petrea study amongst the follicular lymphoma community, we'd be really delighted with that.
Definitely. Yeah, thank you both so much. I think it's fascinating listening to the development and the history of how we get to where we are today with the treatment. Sorry, I can't get the microphone to work. And thank you, Professor Rummel, for your wonderful presentation as always, and the history, and also Judith for going through how clinical trials come about and where we can go from there. So I'm going to open up to the floor. We've had a lot of questions from our online people as well, so we're going to be trying to share the questions around a little bit and get to as many questions as possible. So is anyone on the floor to start things off? Right in the middle there.
We might use you as another microphone person, Nikki.
I'm just quite curious, since regards to, it was very interesting to see the information about the overall survival rates with the extended duration of time after the various treatments. I'm curious, being relatively young, I guess, what the average or the age of the participants were when they underwent the study, and whether it's been looked at various age groups and their survival rates.
Do you want to answer that first?
Yes, typically the studies have a little bit younger patient group, because typically a younger patient feels more ready and fit and motivated than a 70-year-old man who is not so much interested in doing this additional effort. But the median age in the studies typically is 60, 64. That means some patients are 40 and some patients are 80. And the younger patients live longer. This is absolutely clear. This is the most important relevant factor for the overall survival expectancy. And even if you do a clinical study in acute leukemia, a 2-year-old baby has the longest chance to survive compared to a 20-year-old and a 40 and a 60. That is the biology of life. When you're very young and very fit and newborn, you have the best ever to tolerate every treatment and the best out of treatment. So it goes a little bit down with the age, and the median age in these studies is between 50, then it's too young as a median. Some studies have 60, and some studies already are done for, in particular, elderly people when the median age is 70.
And with that sort of median age, in terms of predictions of overall survival, because every single clinical trial adds and adds and adds, it's actually very hard to pull out my crystal ball and make predictions as to, you know, how old the patient will survive who comes into my clinic with newly diagnosed follicular lymphoma in 2019. It's, you know, through your participation in trials, it's becoming very, very difficult to predict.
I'd just like to know your opinion on whether or not genome profiling would have any use with the treatments before a patient starts treatment.
Yes, genome profiling is of course a new way of medicine. We have a big hope for that this will be implemented and help us guiding treatment and have better treatment in the future. We are doing such, for example, this kind of research in my clinic. We do it since 1 year. We have 270 patients. all looked for the genetic mutations of this disease. This is not the same as a genome, because when you analyze your genome, you have maybe to ask the computer machine to work for 30 days, because you have a lot of genes. But when you just look for the type of genes which are responsible for lymphoma disease, you can make it within 4 hours or so with a good computer system. We have done it. We have collected. We find in one patient 22 genes mutated, in the other only 2, in the other no one, and in the other 80 genes mutations, so very wide variety. And we will learn out of these results if the one patient needs a better treatment or another treatment with this type of mutation. But this result is not yet available. We cannot conclude some treatment changes up to now. It was already done in other diseases. So we know it from other, like chronic myeloid leukemia, ALL, acute leukemias, and we will have the same model available in lymphoma than we have it, for example, in acute leukemia. So I think the path in the future is already written down on the paper, but it's not yet reality.
Is there much research into it at the moment?
Pardon me?
Is there any much research into genetic profiling?
Yes, it's a lot of research ongoing, but it's a very expensive research, and usually also not funded by some pharmaceutical companies. You need the government. Sometimes, you know, the government, of course, tells you, yes, we are interested, but in the end, they don't give money. So it's a dilemma. And so that's the reason why in each big country, there are maybe 3, 4, 5 centers of excellence who are doing this work. Also in Australia, it's done, as I know, in high centers of excellence, like in Melbourne and in John Seymour's clinic, Peter McCannon. They do such programs. But it needs to be done. And in the end, there's a puzzle of information will be presented at all the international meetings in the next years. And we learn from each other, and then we will find the way.
I have to say, WeHi will do gene profiling of the cancer for a number of our diseases. They don't really do it for follicular lymphoma. Sorry?
I'm hoping in the future.
Look, I hope in the future that they will, but we must be doing it in the context of clinical trials, in terms of getting correlative science, say within the Petrea study. We're storing specimens within the Petrea study. Right? All we got from the Medical Research Future Fund was enough money to collect the specimens and transport them to a biobank. We don't have enough money to do the immunology studies that we'd really love to do with follicular lymphoma, and genetic profiling, you know, we just don't have the money to do. But what we must do, if we're doing genetic profiling, we need to do it with a big body of clinical data, right? So it can be paired with patient outcomes. Because your own genetic profile of your follicular lymphoma helps me not one jot at the moment.
Yeah, and the interesting thing, very fascinating, that we find the genetic mutations not only in the biopsy, but in circulating DNA of the blood. So this is called liquid biopsy. In the future, my program wants to have the future. In 3, 4, 5 years, we only do liquid biopsies. That's a regular blood control. We do not need CT and PET-CT.
Yep.
Maybe we can read everything out of the circulating DNA of these mutations in the blood. That is science fiction, but maybe it comes true.
Okay, I've got a couple of questions from that have been submitted online. But just before I do, I just want to introduce myself. My name is Nikki, and I run an online Facebook group called Living with Follicular Lymphoma. Do we have any of the members here? Oh, great, excellent. So if you want to know a little bit more about the group, come and see me, or I've got some cards out in front. So anyway, the first question is, do you use Navthera subcat in Germany?
Yes, we have asked the patients in a study, which is called Prefmap study. All patients get IV and subcut, and afterwards we ask the patient what you prefer. 85% said we prefer subcut because we needed less time in the clinics. So it was very convincing results. However, in Germany it's hardly used. It's very rarely used, and this is maybe the reason is a little bit a reason, because the medical reimbursement system does not pay money for the sub-Q injection, but it gives some reimbursement money for the hospital when they make an infusion. So suddenly my nurse, who is the best nurse for cancer disease at all, a 60-year-old lady, quite experienced, has no interest in science and business. She just make treatment. And then suddenly she came in my office and says, "Oh, professor, maybe when we now have more and more sub-Q treatments, maybe my job is not needed anymore." So these are the things in the story which is also influencing, yes. Of course, patients prefer it, but unfortunately, the hospital gets a little bit less incentive of the reimbursement of the healthcare system in Germany, which is ridiculous, but this is the case. Therefore, sub-Q is not given too much in Germany.
Same in Australia. We don't use it. We do use it for certain patients, and certain patients we do prefer it. But the reimbursement issues are a disincentive to using it. One of the clinical trials I really wanted to do, you know, it's a bit of an extension of the PrEFMAP, was actually do a pilot study of self-injecting. Patient injecting the MabThera, the subcut MabThera themselves after they've been shown the first time in terms of patient preferences. And I had this envisaged, this self-injecting room in Concord Hospital where patients would come and be supervised, and they could get in and they could get out. But I tell you what, the nurses and certainly the company were somewhat horrified at the thought of that. But the product information only requires it to be administered under the supervision of a physician. It doesn't actually say who needs to administer it. And you think of all the diabetics and haemophiliacs who are self-injecting themselves. But no money for that sort of trial.
Okay, and what about the use of antibody drug conjugated? The antibody.
So there are some new developments that not only the antibody is given, but it's something added to the antibody, another cytotoxic or effective drug. There are many things on the market, and sometimes we call it B-specific, not only antibody way direction, but another mechanism of action. And that is, of course, hope for the future, that a better developed antibody which is added with another effector mechanism can have more effect on the disease. So there are something on the market. And also it was, as I told you before, this radioactive compounds added to the antibody, but then they disappeared from the market. So there's always hope, and then in the end we will see if in real life it really works.
Radio-labelled MabThera is still used in Western Australia. I mean, the clear example of the antibody-drug conjugate being very effective in lymphoma is the antibody-drug conjugate of CD30, which is used conjugated with a toxin. You know, it's quite a toxin that's delivered to the CD30 positive cells. And it's used and it's approved in Australia for patients with relapsed Hodgkin's lymphoma in the second relapse or refractory disease, and for relapsed anaplastic large cell lymphoma after second relapse. And it's very effective. It prolongs progression, what we call progression-free survival. But because the toxin also affects peripheral nerves, patients end up getting a peripheral neuropathy very commonly with this drug. So I wouldn't say there's been huge development in antibody-drug conjugates in follicular lymphoma. So if I was Googling the web with respect to follicular lymphoma, I wouldn't be spending my time Googling about antibody-drug conjugates. Is that a fair enough statement at the moment, Matthias?
Yes.
Right, there's lots more important stuff to be searching.
Fantastic. Any more questions on the floor?
My question's about the PBS, and we've seen a bit today about the efficacy of bendamustine and rituximab. I guess the question's probably to Judith. Is there any chance of bendamustine and rituximab coming under the PBS for patients with relapsed follicular lymphoma? I know there's so many other
I can't answer that.
questions to be-
I think eventually it will happen. I base my therapeutic advice to patients on that basis, when sometimes I say for a particular reason I would prefer to give rituximab and CHOP to a patient rather than rituximab and bendamustine. because I think eventually it will become PBS listed in the relapse setting. It's a bit of an anachronism that it's not. Just one important thing to remember too, that when it is rituximab and bendamustine as approved in the frontline setting, rituximab maintenance is not approved, all right, in the frontline setting. Now here's the catch. Obinutuzumab, the new antibody, and bendamustine has been approved frontline along with the obinutuzumab maintenance, all right? No, frontline. So if you use R-benda frontline, you can't get the rituximab maintenance. If you use obinutuzumab bendamustine frontline, you can use the obinutuzumab maintenance. And what we are negotiating with Roche is that when we extend the Betrayer trial to include obinutuzumab, they will also give us free supply of Roche for the maintenance after R-bendamustine. I think one key message I want to give, and I've used R-bendamustine a lot until I sort of started screening patients for the Betrayer study, and 2 of my patients have said, yep, well, I'll get on board with Betrayer. That sounds a really sensible PET response adapted approach. R-bendamustine is a great therapy, all right, and it does prolong progression-free survival. But I do think there are later toxicities that patients end up sort of having to sort of pay the price for, in terms of, particularly if you are, patients sometimes choose to pay for their own rituximab maintenance. I think whatever happens, unfortunately, in management of follicular lymphoma, and I think obinutuzumab and bendamustine is a case in point. Better PFS, better progression-free survival, more toxicity. And you've got to pick your patients, and the patients have to pick, whether they want to make that trade-off. That's my very simplistic approach. And so, there's a lot of patients who I think obinutuzumab and bendamustine or rituximab bendamustine is a great approach.
I just wanted to mention, I think one of the things that we do want to know about is in the relapse setting for follicular lymphoma. So in Australia, would you see bendamustine is something that we should be advocating for as a second-line treatment? And if that's the case, I guess what I would like to say to everybody here is this is where we have an opportunity to influence what does get approved in Australia. So we've been really lucky over the last 30 months. The Health Minister has approved 13 new listings on the PBS for lymphoma. This is another one that we potentially truly feel we need, and sometimes we have to initiate that so that the sponsor, meaning the pharma, actually puts it in. So when Lymphoma Australia says, we need your help, this is going to PBAC, can you tell us why you need it, what the difference it's going to make? We truly need that, because I think that's why, working with the doctors and everyone, we've managed to get those 13 listings so far in a very short space of time, but we want more. And I was really interested, Professor Rummel, there was a trial that you had in relapse setting, I think, in Germany, and I don't think we have it in Australia, where there's obinutuzumab, bendamustine, and rituximab. Was that the trial?
There are many trials in relapse disease. The one trial which was done with bendamustine was bendamustine rituximab against fludarabine rituximab, and the clear winner was bendamustine rituximab, because maybe fludarabine was a bad comparator. Yes, of course. But this is what authorities and something like PBS love. They don't care if the one comparator was really very bad. They see it's a big difference, and then maybe they have justification to get it on the list. So that is the reason that many countries worldwide have put bendamustine immediately on the list on second line, because of that, in my eyes, quite simple and not very smart study. I did it, bendamustine against fludarabine. I was not convinced, but all authorities around the world loved it.
And what do you think, if we end up in Australia, we could be pushing to get R-benda in the relapse setting, but then what do we do about obinutuzumab bendamustine in the relapse setting?
Yes, obinutuzumab and bendamustine was a
Gadolin,
gadolin
wasn't it?
study.
Yeah.
It was in rituximab refractory. Most countries of the world have adopted it and listed in refractory patients. I think only United States have that relapsed patients also.
Yeah.
So in Germany, it can only be given when the disease did not respond to rituximab-containing treatment.
Yep. And we've also got a catch, and you can help me here, Sharon. I think on the basis of the gadolin, we're allowed obinutuzumab bendamustine in the rituximab refractory, aren't we?
Yeah.
So you can actually, if they haven't had bendamustine before, or if they haven't had, So you know, it's incredibly complicated, and it's very much based not just on the patient, not just on the doctor, but the healthcare system that you live in, and the healthcare system you think you might be living in 10 years' time if you relapse. All right, and it's incredibly complicated, the therapeutic decision making, and I'm going to sound really ageist here, but for the very young patient with follicular lymphoma. Because for that patient, I am thinking, you know, their lifespan, they had ordinarily expected to live for another 40 years instead of living for another 20 years. And it's sort of quite easy for us who know a lot about follicular lymphoma to think about how we'll sequence our therapies for another 20 years of good quality life. It's really hard to crystal ball gaze about your therapeutic approach for the next 30 years.
But I think
She has
one
a
of the
question.
good things. Yeah, sorry.
Oh, thank you. Just wanted to know about peripheral neuropathy, and do you recommend using methylcobalamin B12 injections to improve the nerve fibre and repair that?
I'm not aware of any data to support that. Are you, Matthias?
No, that is what the house practitioner, the house doctor, family doctor is recommending because he wants to do some action. That's my feeling. Give vitamin B. And the other thing, it does not improve the side effect peripheral neuropathy once you have it from chemo. Unfortunately, you can only influence it with this pregabalin, with the treatment, which is reducing this feeling of irritation. But you cannot turn it back just by taking vitamin B.
It was the methylcobalamin that I was referring to rather than standard.
I have no knowledge of any evidence to support that.
Right, okay.
Same to me, I don't know it.
Okay.
I've got a question from online. What is the role of CAR T-cell therapy in relapsed follicular lymphoma?
I think the Germans are probably more advanced than we are in Australia.
We just have opened a lot of centers for CAR T-cell treatment, very, very new treatment, totally different kind of action of treatment, and it is not available for relapsed or for follicular lymphoma, and this will not be the case in the next years, I'm quite sure. It is for the very aggressive lymphoma, pre-treated, and once a follicular lymphoma will become very aggressive because the biology of disease has changed and suddenly it's not a low grade but a high grade, an aggressive lymphoma, maybe in these very, very rare circumstances in the future, CAR T-cell may play a role.
Yeah, well, I've sent 2 patients with transformed follicular lymphoma to have CAR T-cell therapy, and both have done very well. As Professor Rummel says, CAR T-cell therapy has a particular role, and the biggest area of data is in the acute lymphoblastic leukemia, is in the aggressive lymphomas. I think we have to be very careful. I might be very unpopular when I say this, and I believe in CAR T-cell therapy as much as anyone else, all right? But there is a lot of patient selection for the CAR T-cell therapy trials. There's a lot of selection in terms of, you know, the numbers of patients who actually end up getting the CAR T-cells. The CAR T-cell approach is constantly being modified and refined. You know, inch by inch it's moving ahead, but there is yet no phase 3 randomized clinical trial comparing CAR T-cell with, say, standard treatments for relapsed diffuse large B-cell lymphoma across a broad inclusion criteria. It's got great promise, and as you know, it's now received a lot of funding, which is wonderful, down at Peter MacCallum Cancer Centre. The Westmead people here in Sydney and Prince Alfred Hospital are the two sites who have been sort of assigned to develop CAR T-cell therapy in New South Wales. So it is coming, but it's still relatively early days.
So is there trials going on at the moment with it?
Not with follicular lymphoma.
No, but if it changes into the aggressive?
Yes, again, you'd have to go and have a check under aggressive lymphoma on the ClinTrial Refer app. I think at Westmead they've still got their CAR T-cell trial open, but it's for patients who have failed allogeneic transplant. So that really narrows the criteria. Yeah. But your hematologist is well aware and keeping their eye very close to the developments in CAR T-cell therapy.
Okay, all right. What part do blood tests play in the management of lymphoma? If on watch and wait, should regular screening tests be done? If blood tests show abnormal lymphocytes and a worsening trend, should this be investigated?
Matthias, how long have you watched and waited someone with circulating follicular lymphoma cells? What's the longest you've watched and waited?
Circulating lymphoma cells, we know of course from the CLL, and we learned that also we can make watch and wait a long time in some circumstances. But I think the question was what you do when monitoring after the treatment. Monitoring maybe after the treatment, yes. And you see of course abnormal lymphocytes, I would say, in every patient, because maybe before the treatment you have maybe sometimes normal lymphocytes, but after treatment always lymphocytes are depleted and below the normal range because of this treatment. This treatment goes against the lymphoma, and also the same word is the same origin, lymphoma, lymphocytes. So this is a compartment of the body which is hit by the treatment. Lymphocytes are a little bit depleted then, and it's a higher risk of infection, but the monitoring is more to see the patients, to talk to the patients, to find its clinical position and clinical situation, how well is he being. Blood tests may play a minor role in monitoring, but it's always being done.
And likewise, imaging plays a very limited role in monitoring follicular lymphoma. There is no role for PET scanning for surveillance after you've achieved remission. And there may be a limited role for CT scanning in the patients who've had quite bulky abdominal disease, who presented quite symptomatic of their disease, but didn't have much in the way of peripheral nodes to monitor them. There's definitely a small role for that. Sorry, but it's mainly touch and feel, and the feel, more about the feel, is how the patient feels.